I've been dispatched to a 7-year-old male called Bernard. He's had an acute onset of chest pain and a collapse. Bernard has had a MI 5 years ago, but he describes the pain he's feeling now different to that. Bernard is feeling dizzy and lethargic and appears to be pale and clammy. Bernard is feeling palpitations and is feeling as though his heart is going to jump out. Bernard seems confused and has a GCS of 13 made up of E3, V5 and M5. I've taken a full set of vitals and it's come back with a heart rate of 170, BP of 70/30, rest rate of 24, temperature of 37 and BGL of 7.6. On auscultation I found that his lung sounds were normal. Bernard is feeling short of breath and saturating at 90%. He has a peripheral capillary refill of 5 seconds and central of 3 seconds. I've considered the secondary causes including hyperkalemia, sepsis, drug overdose, and SVT with aberrancy. I'm now going to lie Bernard on the ground in the supine position. So I've now got Bernard in the supine position and I've completed a further assessment. I've already called for an R50 and they're on their way. We've also already got a 12-lead ECG just to get a prediction of what sort of rhythm Bernard is in. So it looks as though it is in VT, and this is shown by the wide QRS complex, the extreme right excess deviation, and I can see some capture beats. This means it's much more likely to be VT than SVT with aberrancy. I'm also leaning a lot more towards VT due to his history of an MI and his age. So at this point I'm going to need to determine a cardiovascular compromise. So I can still see that by his blood pressure that he's still severely hypertensive. I can also see that Bernard is still short of breath and he was saturating at 80%, which is why I've put on oxygen high flow at 15 litres per minute. I'll now need to just check for a pulse. So I'm checking both carotid and radial. So I'm not currently getting a radial pulse, however the carotid is there. I'm now going to check if Bernard can obey my command. So Bernard, can you please squeeze my hand? Okay, so Bernard is unable to obey commands. So due to all this information, it looks as though Bernard is in severe cardiac compromise. So at this point, I need to start preparing for a cardioversion. So there are 2 types of cardioversions. There's chemical or electrical. But since Bernard is in severe cardiac compromise, I'm going to go down the electrical route. So I've already gained bilateral large bore IV access, and I'm now going to start going through my cardioversion checklist. So the first step is to place the pads, which I've already done on the apex and the sternum. I've also already ensured that the monitor is in manual mode, and I've already selected the joules at 360. So I'll need to select a lead with a visible R wave, which I've already done, and in this case it's lead 2. I'm now going to synchronize. I've gone synchronize. I'm now going to print the rhythm and ensure that there is a detection symbol above every QRS complex. So I can see that there is a detection symbol above every QRS complex. Cool. So at this point, I would normally need to ensure that the patient has received adequate sedation. However, in Bernard's case, he's unable to obey commands, so this is not necessary for him. So yeah, I've already selected the joules. I'm going to charge the defibrillator and ensure that everyone is clear. So charging, so everyone needs to stand clear. I'm then going to hold and press the shock button until the shock is delivered. Cool, so pressing and holding. Shock has been delivered. Okay, I'm now going to need to redetermine the rhythm. So I can still see that Bernard is in VT. I'm going to reassess his ABC, so his airway is still looking patent and clear. However, he is still short of breath. I'm now going to recheck his pulse. So I'm still not getting a radial pulse. However, the carotid's still there. I now need to check. So Bernard, hello Bernard, can you please squeeze my hand? So Bernard is still unable to obey commands. So at this point I'm going to administer a second cardioversion. First I will need to still confirm that I'll need to sync again and confirm that the detection symbol is there by reprinting. Yes, okay. So I'm going to recharge and then reshock. Okay, so charging. And I'm going to press and hold the shock button. Okay, so make sure everyone's clear. Pressing and holding. So the shock has been delivered. I've been dispatched to a 40-year-old male who has fallen off a 6-metre roof onto the driveway. He has damaged his occiput, and his friend has noted that he was water blasting and slipped and fell. There is a 6-centimetre bulky patch on his occiput, and the patient is now in the supine position, presenting as restless and combative. He has a rigid extension of his arms in response to a painful stimulus, giving him a motor score of 2. He is opening his eyes to pain, and he is moaning and groaning. This gives him a GCS of 6, made up of E2, V2 and M2. He has irregular respirations and grunting, and backup with RSI capabilities are 10 minutes away. He has no known medical history, and I have taken a full set of vitals with a heart rate of 50, BP of 160 on 110, rest rate of 12, however this is irregular, and a BGL of 6.6 with a temp of 37. So I'm now going to assess the GCS of the patient. So his eyes are opening to pain, which gives him an E score of 2. He is moaning and groaning, giving him a verbal score of 2. And he has a rigid extension of arms in response to a painful stimulus, giving him a motor score of 2. So this gives him a total GCS score of 6, made up of E2, V2 and M2. So an R50 has been called, and they're on their way, and they've told us to prepare for an RSI. So I'm going to prepare for an RSI using my CPG's RSI checklist. So I've already attached nasal prongs without oxygen. I'm also already pre-oxygenating using a reservoir mask at 10 litres per minute. You can also use a manual ventilation bag, which I've already prepared over here with PEEP at 5. I've also attached my ECG, the blood pressure cuff and an SpO2 monitor. And I've prepared capnography, which is just here. So I've also positioned the monitor so I can see it. I've left space to the right side of the patient's head for intubation equipment for ICP when they arrive. I've gained bilateral IV access, large bore. I've also prepared a running line of sodium chloride. I've positioned the patient for optimum airway control, so I've used these towels in order to keep the patient's optimal airway. I've also placed an ETT holder with a strap undone under the patient's head, shown here. I've ensured that the suction is working, so I'm going to do that now. Cool, so that's working, and I'm going to turn it off. I'm going to prepare, so that I've already prepared the ventilation bag with PEEP attached. I've also already done a full set of vitals. I've already updated ICP with the patient condition and vital signs, which I did when I called them earlier. I gave them all of that information. I've prepared the area, so I've cleared all the unnecessary equipment. I've left space available on either side of the patient. A failed intubation drill is started when the R50 cannot visualize the vocal cords within 15 seconds or are unable to intubate within 30 seconds of laryngoscopy. If this occurs, then the patient should be manually ventilated. The intubator should then consider using a different blade or retrying with a bougie or using anterior tracheal pressure. After the second attempt, if the EtCO2 is greater than 5 after 2 to 4 breaths post-intubation, procedures should be as followed. If not, the ETT should be removed and an LMA, NPA or OPA should be used. If this works, then airway should be managed using basic airway care. If this is not possible, a cricothyroidotomy should be performed. A cricothyroidotomy is used to obtain access into the trachea when a normal intubation has failed. A scalpel is used to create an opening to fit an ETT tube to allow for ventilations when all other options has failed. A bougie is used when an intubation may be difficult or the initial intubation has failed. The bougie is more rigid and thinner, making it easier to pass through the vocal cords. Once the bougie is in the trachea, the ET2 tube can be passed over the top of the tube and threaded into place.